Good morning, everybody. Today we are going to talk about role and scope of ultrasound in clinical anatomy. In this brief session, we'll talk about ultrasound waves and their use in living anatomy. We will also discuss role and scope of ultrasound in clinical and sectional anatomy. Ultrasound waves are defined as sound waves beyond the ordinary limits of hearing. Generation and detection of ultrasound signals is based on piezoelectric effect. This effect was noted by Parry and Jacques Curie in 1880. Ultrasound has achieved wide clinical use since 2070. The frequency of ultrasound waves used in diagnostic ultrasound ranges between 2.5 to 14 megahertz. Ultrasound is now regarded as the basic investigation. It is widely performed for diagnostic purposes. It is also used during interventional procedures like paracentesis, taking biopsies, giving nerve blocks and intravenous fluids. It is also used for monitoring fetal status during pregnancy, can be used to teach anatomy. Medical graduates need to have basic knowledge of ultrasound. Therefore, living sectional sonography anatomy must be included in undergraduate curriculum. Our Department of Anatomy at Government Medical College Srinagar started teaching of sectional anatomy using ultrasound in 2011. Some of our faculty members were trained in the Department of Radiodiagnosis and Imaging at SMHS Hospital. Then we included ultrasound in teaching curriculum both for UGs and PGs. We assess these students by keeping 2 to 3 supports in final and internal exams. One of our postgraduate pass-outs worked on the research project based on ultrasonography. Our ultrasound lab consists of a room, examination table, USG unit which includes monitor, transducer, coupling gel, towels. The ultrasound lab of a department is located in a separate room containing a table for examination of the patient and a USG unit which consists of monitor, transducer. We use coupling jelly at the interface between the second and the transducer. Towels and screen is used for cleaning and privacy. The components of an ultrasound machine are a transducer which converts one form of energy into another form, central processing unit, a display, keyboard, coupling gel. How does ultrasound work? The transducer converts electric signals into sound waves. These waves, after passing through the tissues, get reflected back and are picked up by the transducer. These signals are then sent to central processing unit, which converts them into an image which is displayed on screen. This image can be recorded or it can be printed out, which can be given to the patient as the USG film. What do we get after placing USG probe on a patient? Depending upon impedance of tissue, which is product of velocity and density, these ultrasound waves get either absorbed, reflected, or refracted from the tissues or body. What is acoustic window? If we have to examine retroperitoneally located pancreas, these sonographic waves have to pass through the stomach. But if stomach is filled with gas, we cannot visualize retroperitoneally located pancreas. So we make the patient to drink water. Now the water-filled stomach acts as a window for the passage of these sonographic waves which strike pancreas, and we get an image of pancreas on screen. Same is true for pelvic ultrasound. In females, the structures located in the pelvis from anterior to posterior are urinary bladder, uterus, and rectum. Urinary bladder and uterus, they are pelvic organs. Now, if we place the probe on symphysis pubis, these waves cannot pass because high density of the bone. Now, if we place the probe above the symphysis pubis, again these waves cannot pass because the lesser pelvis contains coils of intestine. So we ask the patient to come with full bladder. Urinary bladder, which is a pelvic organ, can ascend up to umbilicus when filled with urine. This filled bladder acts as an acoustic window for ultrasound waves. which pass through it strike the uterus and we get an image of the uterus on screen. In case of males, sonographic waves pass from filled bladder and we can localize prostate. Thus, bladder acts as an acoustic window both for prostate in males and posteriorly located uterus in females. As shown in this diagram, these waves pass through the filled urinary bladder, strike uterus, and we get image of both bladder as well as that of uterus. As already said, in ultrasound we get three types of images. Hyperechogenic, if they are more echogenic or brighter than normal. In this pic, diaphragm appears hyperechogenic. This is because of the fact it contains muscle than the surrounding structures. Hypoechogenic is less echogenic or darker than the normal. In this pic, you can see the blood-filled hepatic veins or portal veins appear darker than or less echogenic than the surrounding structures. Isoechogenic. If we compare the echogenicity of the two blood vessels, both contain blood, they have same echogenicity and we call them as isoechogenic. Ultrasound is just like histology. Depending upon the direction of the probe, we can take a longitudinal section or a transverse section. In this figure, transducer is placed longitudinally in the mid-axillary line. The waves pass through liver, strike the kidney, and we get a longitudinal image of the kidney. Here we can see the right lobe of the liver, right kidney, and hepatorenal pouch. We can take the measurements of the kidney using ultrasound. Normal measurements of the kidney, its length is 12 centimeters. Its breadth is 6 centimeters and anterior-posterior diameter is 3 centimeters. Now, if we change the direction of the probe, now we placed the probe transversely, so we get a transverse section of the kidney. So, depending upon the direction of the probe, we can take a longitudinal section of an organ or tissue or a transverse section of an organ or tissue using ultrasound. Let us go for a quiz based on this lecture. So what is this? So in this diagram I have marked many structures. What are these? 1, 2, 3, 4. I know you cannot answer them. Now let us go for next slide. This is ultrasound of the liver. You can see here diaphragm which is inferiorly placed there is hyperechogenic than compared to the liver shadow. Now if we go to this ultrasound, this again ultrasound of the liver, where we can see the gallbladder with a stone inside. These waves strike the stone. Stone does not allow them to pass through it. So we get an acoustic shadow underneath the stone, which is diagnostic of a GB calculus. The rest of the lumen of the gallbladder appears hypoechogenic as compared to its walls, which is hyperechogenic. Again in this slide, you can see a stone within the gallbladder giving an acoustic shadow. What are the functional lobes of the liver? On surface, we can see right and left lobes of the liver separated by the falciparum. If we draw a line from gallbladder fossa to inferior vena cava, what we called as the Cantel's line, it divides liver into left and right functional or physiological lobes. These lobes can be picked up by ultrasound. In this section, this is gallbladder fossa, this inferior vena cava, and the line connecting between the two is interlobar fissure, which divides this liver into right and left lobes. Now if we turn liver upside down, we can see the three hepatic veins, right, middle and left, draining into inferior vena cava. If we take a section of the liver, you'll see there this pattern of hepatic vein is called inverted umbrella sign. What do we see there? Right hepatic vein, middle hepatic vein and left hepatic vein, they drain into inferior vena cava. And this arrangement is called inverted umbrella sign. In this diagram, you can again see line connecting the gallbladder fossa with inferior vena cava is called the interlobar fissure, which divides the liver into right and left lobes. Again, a section of the liver, where we can see the inferior vena cava passing through the substance of the liver and entering the right atrium. At the same time, we can see one of the hepatic veins. In this section, we see gallbladder, interlobar fissure, right portal vein, and left portal vein. Now the question is how you will differentiate between right and left portal vein. Yes, anybody? Portal veins are differentiated from hepatic arteries based on echogenicity of their walls. You can see portal veins are hyperechogenic as compared to hepatic veins which are hypoechogenic. Again in the section of the liver we are seeing the gallbladder. Again in this section there is gallbladder, hepatic veins with hypoechogenic walls. In this section we can see the portal vein dividing into right and left branches. Portal vein, as already said, walls of the portal vein are hyperechogenic. Now in anatomy you will not find the term length of the liver because it is an irregular organ. But in sonographic anatomy we say length of the liver is 16 centimeters. We take this length from diaphragm to the lower pole of the kidney by placing a probe in mid-clavicular or mid-axillary line. As shown in this diagram, probe is placed in the mid-axillary line. We take the dimension from diaphragm to the inferior margin or border of the liver. Again, the measurements are taken from the undersurface of the diaphragm to the inferior border of liver. So this is how we take measurements of the liver in longitudinal section, and normally this length is 16 centimeters. Now in this section we can see the right kidney, a longitudinal section, right lobe of the liver. At the interface between the two is a glistening surface. This glistening surface is hepatorenal pouch of Morrison. The kidney is divided into cortex and medulla. Outer cortex is hypoechogenic, medulla is hyperechogenic. Cortex contains glomeruli, or it is the secretory part of the kidney. Medulla contains collecting system of the kidney. Medulla appears hyperechogenic in normal sections. Now identify L and identify K. L is the right lobe of the liver, K is the right kidney. Identify UP and LP. UP is the upper pole of the kidney and LP is the lower pole of the kidney. Lower pole of the kidney lies medially and upper pole of the kidney lies laterally. Now in this section we can see the hepatorenal pouch appears as glistening at the interface between the right lobe of the liver and anterior surface of the right kidney. If we can take the measurement of this kidney in longitudinal as well as in transverse direction. Cranial end of the kidney lies laterally and caudal end of the kidney lies medially, and the length of the kidney is 12 centimeters. Now what is Morrison's pouch? From the anatomical knowledge we know that Morrison's pouch is also called hepatorenal pouch. It is the most dependent part of the peritoneal cavity in supine position. That is why surgeons keep their brains. That's why during the past we try to see fluid in this cavity. This potential space lies between undersurface of the right lobe of the liver and anterior surface of the kidney and appears glistening under normal circumstances. So in this diagram, A represents right lobe of the liver, B represents right kidney. This glistening line represents hepatorenal pouch of Morrison. Now if this pouch is filled with fluid, it gives hypoechogenic shadow as occurs in trauma to the abdomen and other pathological conditions where fluid accumulates in the peritoneal cavity. In this diagram, you can see the hepatic artery, portal vein, and common bile duct. This is again a section of the liver where you can see inferior vena cava and portal vein. Portal vein is again identified by hyperechogenicity of its walls. So normal kidney consists of outer cortex and inner medulla. Cortex being hypoechogenic and medulla is hyperechogenic as shown in this diagram. Now what is hydronephrosis? So kidney consists of two parts, outer cortex, inner medulla. Medulla contains collecting part of the kidney. Suppose there is obstruction due to any cause. It may be due to an aberrant vessel, it may be due to stone or due to structure. It leads dilatation of the renal tubules which lie proximal to the obstruction, and these dilated tubules cause compression of the renal cortex. On ultrasonography we can pick it up because collecting system of the kidney is filled with fluid. It no more appears hyperechogenic but is hypoechogenic as shown in this diagram. Renal cysts can be also diagnosed by an ultrasound. You can see these multiple cysts appearing as small hypoechogenic cavities surrounded by hyperechogenic walls. If we go to the ultrasound of the pelvis, the structures which are present in female from anterior to posterior are bladder, uterus, and vagina, and posterior to the uterus is pouch of Douglas. We can also see the abdominal vasculature on ultrasound. We can see abdominal aorta and its branches. Normally, in case of abdominal aorta, ultrasound is done for an aneurysm. An aneurysm is a dilated vessel. In case of abdominal aorta, if the transverse diameter is greater than 3 centimeters, we say it is an aneurysm. Up to 3 centimeters, we take it as normal. Commonest site of aneurysm of abdominal aorta is below the origin of renal arteries. In ultrasound, we take outer to outer wall dimensions to measure the diameter of blood vessel. If outer to outer wall diameter is greater than 3 centimeters, we say an abdominal aortic aneurysm is present. Abdominal aorta gives paired and unpaired branches. Paired branches are for paired viscera like diaphragm, suprarenal, kidney, and gonadus. Unpaired branches are for gastrointestinal tract, which include celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Celiac trunk arises from abdominal aorta. It divides into three branches: splenic artery, hepatic artery, and left gastric artery. On ultrasound, we can see celiac trunk dividing into right and left branches. Abdominal A is abdominal aorta. It gives celiac trunk, which divides into splenic artery and hepatic artery. Since this pattern resembles a seagull, we call it as seagull sign. If it place the probe longitudinally in the midline on anterior abdominal wall, we get the longitudinal section of abdominal aorta with the vessels originating from it. The first unpaired vessel is celiac trunk, followed by the superior mesenteric artery, which lies parallel to the abdominal aorta. So in this diagram, we can see celiac trunk and superior mesenteric artery originating from abdominal aorta. Abdominal aorta divides at the level of L4 into right and left common iliac arteries, which can be picked up by the ultrasound as shown in this diagram. So abdominal aorta divides into right and left common iliac arteries. Now going to the pancreas. Pancreas is divided into uncinate process, head, neck, body, and tail. Splenic vein passes through substance of the pancreas, disjoined by the superior mesenteric vein to form the portal vein. Between the inferior border of the pancreas and uncinate process like the superior mesenteric artery, which acts as a landmark for pancreas. In sonology, it is said that body of the pancreas wraps around the splenic vein. Now, if we go posteriorly, we find that the splenic vein joins the superior mesenteric vein to form the portal vein. By taking an ultrasound of this region, we have superior mesenteric artery is there, which lies between the uncinate process and body of the pancreas. Splenic vein leaves the hilum of the spleen. It drains into the portal vein. And this diagram, you can see portal vein into which drains the splenic vein, and anterior to it lies superior mesenteric artery. Now, what do you see in this figure? Portal vein into which drains the splenic vein. We see the inferior vena cava as well as left renal vein draining into the inferior vena cava. Abdominal aorta is also there, and superior mesenteric vein. The yellow curved circle represents the body of vertebra. We can feel the pulsations of the abdominal aorta while doing ultrasound. So in this diagram, this hyperechogenic shadow which wraps around the splenic vein is pancreas. As shown in this diagram, the visceral relations of the spleen are Spleen is related to the upper pole of the kidney. Ascending colon, tail of the pancreas, and also to the fundus of the stomach, which gives the gastric impression there. So we have there on the visceral surface of the spleen lies the gastric impression. So it is fundus of the stomach. If we remove it, on the visceral surface of the spleen lies gastric impression, then renal impression, where posterior pole of or medial pole of the spleen is related to upper pole of the kidney, then pancreatic impression, which is related to the tail of the pancreas, is related to the hilum of the spleen, and colic impression, which is related to the anterior border. Now, if we go to the ultrasound, we see this hyperechogenic shadow represents pancreatic tissue. In this hyperechogenic shadow, we have there portal vein and splenic vein draining into portal vein and superior mesenteric artery. And again, in this figure, the superior mesenteric artery, pancreatic tissue, and this comma-shaped vein represents the drainage of splenic vein into superior mesenteric vein. And this hyperechogenic tissue which wraps over splenic vein is pancreas. What is this section? In this section, we see two poles of spleen, lower pole of the spleen and upper pole of the spleen. Now, lower pole of the spleen, in this section, we see the two poles of the spleen. The medial or the upper pole of the spleen is related to left kidney. Now, in this section, we can see spleen, lower pole of the spleen, left kidney, which is related to the upper pole of the spleen. We can see pancreas related to the hilum of the spleen, splenic vein leaving the hilum and going towards the portal vein. In this section, we see spleen as well as the left kidney. Spleen acts as an acoustic window for the left kidney. We make ultrasound waves to pass spleen in order to see the left kidney. Now in this section, we can see again spleen, left kidney related to the medial pole of the spleen. So then small vein is emerging at the hilum, joining together to form the splenic vein, and there is also pancreatic tissue related to the hilum of the spleen. In this section, we can see the two poles of the kidney. In this section, we can see the two poles of spleen. The length of the spleen is taken by joining the two poles of the spleen. Up to 13 centimeters, we take the length of the spleen as normal. If it is beyond that, we say it is an enlarged spleen or splenomegaly. Now, in this section, we see spleen and its visceral surface related to the fundus of stomach, as already said. Now, if we go to the pelvis, in case of the males, we see anteriorly located urinary bladder and posteriorly located prostate. We can take the measurements of the prostate to determine its volume. We can also pick up enlargement of its lobes. Now, in this diagram, you'll see this Foley scatter inside the urinary bladder. Foley scatter has two ends. At one end, you find a balloon. This balloon is not inflated. It is inflated only after insertion of the catheter into bladder, and it causes retention of the catheter. Then distal to the balloon is opening through which the urine drains out. So balloon lies in the urinary bladder. At the other end, you will find there urine drainage port as well as another port through which normal saline is injected to inflate the balloon. Balloon helps in retention of the catheter. Now in this diagram, we find urinary bladder and prostate in what is uvula vesicae. Enlargement of the medial lobe of the prostate, which enters into bladder and causes obstruction, is called a uvula vesicae. So it is an enlarged medial lobe of the prostate. You can see on dissection table it the enlarged median lobe. Now if we take an ultrasound of the same patient, you will find that median lobe within the urinary bladder causing outlet obstruction. So if a patient presents with distended abdomen and there is history of retention of the urine, First thing you need to do is to pass a catheter and drain urine. Second thing, you will go for an ultrasound. In this ultrasound, you will find enlarged median lobe of the prostate, which we called as uvula vesicae. In these sonographic pics, you will find cortex is compressed and medulla is hypoechogenic. This occurs in hydronephrosis. Let me ask you some questions. What is physiological capacity of by physiological capacity we mean the amount of urine which gives sense of micturition. It may range up to 320 ml. What is anatomical capacity? Anatomical capacity is the amount of urine which is stored in the urinary bladder. It can go up to the 500 ml. What is pathological capacity? When there is outlet obstruction, the capacity of the urinary bladder goes on increasing. It may be in liters. What is residual volume? When a patient comes with a history of urinary outlet obstruction, we ask the patient to come full bladder. Then we do an ultrasound. We measure the volume of urinary bladder. Then we ask the patient to pass urine. Then we again do an ultrasound. Up to 100 ml of urine within the urinary bladder, we take it normal. If it is more than that, more than 100 ml is abnormal. So the amount of urine that remains in the urinary bladder after passage of urine is called a residual volume. Up to 100 ml, we take it normal. More than that suggests outlet obstruction. Again, you will find a catheter within the urinary bladder, and we can see the seminal vesicles, one on either side. This is a section of the uterus. Anteriorly is bladder, so posteriorly is uterus. This is vagina, and this glistening membrane is endometrium. Now, in this condition, you will see uterus bicornus unicolis. In this section, you see two endometrial cavities beside urinary bladder. This condition is called bicornuate uterus. Now, in this section of pelvis, we see a glistening metallic substance within the endometrium. It is a copper-T, a contraceptive device. In this section, we can see the right and left ovaries. Again, in this section, we can see the right ovary. In this section, we see urinary bladder. Anteriorly, in this transverse section, we see anteriorly located urinary bladder, posteriorly located uterus, and right ovary. This is the sagittal section of the liver. We see liver, right kidney, and hepatorenal pouch of Morrison. What are the supporters of the kidney? Kidney restus and quadratus lumborum and psoas. Here we can see the psoas major forming the posterior support of the kidney. This is a section of the liver. Here we see gallbladder, then portal vein because its walls are hyperechogenic. In this section, we see spleen and left kidney. Now, A is diaphragm, B is some fluid below the diaphragm. Some fluid collection between the spleen and diaphragm usually occurs. In this section, we see spleen, kidney. There is some collection of the fluid between the diaphragm and spleen. If this fluid is hemorrhagic, it irritates the undersurface of the diaphragm and the pain reaches to shoulder through phrenic nerve. We call it as Kehrsign. Here we can see the fluid in Morrison's pouch. Now here in this figure, this one is hepatic vein because its walls are hypoechogenic, and A is portal vein. We differentiate between the two depending upon the echogenicity of their walls. How do we evaluate the students in the examination? You will get a part like this. So part 1, identify the viscera labeled as A, it is the right lobe of the liver. B is right kidney. What is length of B? Normal length of kidney is 12 centimeters. Identify A is a right lobe of liver, B is right kidney, and C is hepatorenal pouch of Morrison filled with fluid. That's why it appears hypoechogenic. Identify AB. What is the length of A? A is spleen, B is left kidney. Length of spleen up to 13 centimeters. We take it as normal. Thank you for watching.